All right. Well, thanks for having me. I'm Alfred Atanda. I'm a pediatric orthopedic surgeon at DuPont Children's Hospital, where I specialize in sports medicine. Telemedicine has been a passion of mine well before COVID, well before it was cool. I've been doing it about 5 years now, but it's very timely in some of the discussions that we've been having lately. And definitely when you're thinking about pushing the envelope and being innovative, telemedicine definitely comes to the forefront. So I don't have any disclosures. So the way I think about telemedicine is really trying to connect people and bridge the gap between clinical providers, physicians, and the patients we treat. Most of the time in the traditional sense, when we interact with our patients, it's really obviously in person. But when you boil it down to its bare essence, really what we're doing is transferring information from us to the people that need to get it. And telemedicine definitely came to the forefront during the pandemic when we had a lot of limitations on what we can do in person. So as we've all navigated the pandemic, there are a lot of things to consider with telehealth in general, and I'm not going to bore you with any of that. Mostly what I want to talk about is a lot of the new and exciting outside of the box things that we're doing. Obviously, there's practical issues and billing and legal and licensing issues, hardware, software issues, things that you do have to navigate if you're going to create a telehealth or telemedicine offering. But once you do get to that point, there's also a lot of new and exciting things that you can do to build on top of that basic foundation of telehealth. So this is me being a nerd in clinic. I have my desktop computer there. I have my iPad, and I'm doing a telehealth visit with a mom and her patient. And that's what a lot of us think of as the traditional way of performing telemedicine or engaging with a patient via digital health. We've done it so much that, we've published research on it. This was our first paper looking at cost savings and decreasing wait times and increasing patient satisfaction. The group from CHOP quickly followed us. Children's Hospital of Philadelphia, their sports team, looked at how knee arthroscopy post-op patients can be looked at. But again, I want to focus more on the innovative telemedicine application. So when we're really thinking about how we can push the envelope, think outside of the box, I kind of think telemedicine is here, people are doing it, it's almost like a household thing. But now what can we do beyond that? So first and foremost, what we've started doing, I'm a sports medicine surgeon, and we're doing a lot of digital telemedicine related sideline coverage. As you know, if any sports medicine docs are on the line here, you know that team coverage is a huge deal. And you have athletic trainers that are on the field typically, and the doctors are there mostly to provide clinical experience, judgment, knowledge, advice. Obviously, we get down and dirty and examine the athletes as well. But I would beg to say, as somebody who's done a sports fellowship and sees athletes all the time, I would beg to say that most of what we do is really transferring that knowledge to the athletic trainer to then facilitate taking care of those athletes. Obviously, if there's something catastrophic that happens on the sidelines, you're going to send the child or the patient to the hospital. You're going to backboard them and put a C collar on and send them off. So our role as surgeons is, we do have a role there. But what we've been doing now is utilizing telemedicine to see and interact with these athletic trainers as they interact with these patients, because now I can do that from the comfort of my own home. I can do it for multiple teams and multiple fields at once, whereas in person, you can only do it one at a time. And I think, having a full practice and doing surgery and seeing patients all day, it's kind of hard and taxing to then, spend 3-4 hours on the sidelines at night. But telemedicine allows us to still move that knowledge, move that information to where it needs to go to, but still have some semblance of our own regular lives. But at the same time, it allows us to be more efficient because we can be in more places at once. Virtual triage and pre-screening is something that's very interesting. One of the things that's kind of a pet peeve of mine is seeing patients that I'm not necessarily the appropriate doc for them to see, or I can't necessarily help them. So we're now virtually triaging patients. We'll find a patient with a problem, usually a brand new patient that calls. My athletic trainer or my ATC will use a HIPAA secure app, kind of like a FaceTime visit, but a telemedicine visit, to interview them, get a sense of their history, figure out what's going on with them, do the basic demographic information, their insurance information, and then really figure out who they need to see at that point. So these are patients who may have been on my schedule, but after we do this little pre-screening visit, sometimes they may need to see a different provider, or they may need to see me, but not necessarily at that time. You know, sometimes people go to an urgent care, they get hurt, and they call my office the same day trying to see me, when in actuality, it may be better to see them in a week or two. Or vice versa, sometimes they have an appointment 3 weeks out from an injury, but I do need to see them the same day or the day after. So by utilizing telemedicine, again, we can gather that information and that knowledge prior to the visit to help us triage the patient, get them where they need to go, answer their questions, manage their expectations. So when they finally do show up to the clinic, the visit can be streamlined, focused on physical examination and decision-making, as opposed to redundant information transfer. This is, we wrote this up and presented it at our sports medicine meeting a couple of years ago, basically showing that we were reducing wait times, we're reducing the times that patients were waiting, not just in the waiting area, but also waiting in the exam rooms for the physician, all the while maintaining appropriate quality of care and patient satisfaction. Family conference is another one. This is a quick story of a patient that I had. I was going to do an anterior cruciate ligament reconstruction or an ACL reconstruction on a Monday. The Friday before, the family realized that they had more questions. But it just so happened that that Friday before, the dad was playing golf, mom was at work. The child who I was operating on was at school. These aren't real people, these are actors, but this is me. I was doing surgery that day. So in a traditional sense, there's no way that we could get everybody together to answer the questions, you know, before the weekend hit, before the surgery on Monday. But my secretary set everything up. We got the telemedicine links and apps pushed out to everybody. And as soon as my cases were done, you know, the daughter was in the school parking lot, mom was at work. I had just scrubbed out, and we were able to have a nice little kind of FaceTime Zoom session just like this, where we were all there. We could all answer our questions, get our questions answered. I can ask, you know, they can ask me whatever they needed to. In the traditional sense, there's no way that could have happened. But telemedicine, again, it took the knowledge from me and it moved it to where it needed to go for all stakeholders involved without really limiting or inconveniencing anybody. Physical therapy is another big area. So a lot of our patients, when we do surgery, they go to physical therapy post-operatively. And what we're now finding is that we can have them do their telemedicine visit while they're at physical therapy. So this way, the physical therapist is there, the mom or dad or the patient is there, and I'm in my office or at home or wherever I need to be. And we have a little kind of three-way call or a three-way session where we can all talk, we can all discuss the patient's progress. The patient can ask the therapist questions, they can ask me questions, the therapist can ask me questions, I can share information and ask questions of them. It's a very multidisciplinary approach because typically the patient will go to therapy, the therapist will have questions for the patient, then the patient will come see me in the post-operative visit and try to remember whatever the therapist was saying, or vice versa. When they go to therapy, they'll try to remember what I was saying. This way, everybody comes together in a way that's convenient, streamlined, and all the information goes where it needs to go. Streamlining ED transfers. So for the trauma orthopods on the call, you probably get a lot of patients being transferred from one ED to your ED. This is a story of a patient. He had this medial epicondyle fracture here. He's a 15-year-old football player. He went to an urgent care in his local community. They saw that he was 15 and he was young and he had a big swollen elbow. They didn't even do anything, and they just shipped him down the road to another urgent care. This urgent care actually got x-rays, realized that he had a displaced medial epicondyle fracture, and said, you know what, we can't take care of that. You need to go to the ER down the street. So, of course, they go to the ER. The orthopods that are there, they don't treat kids. They're adult orthopedists. And they said, well, you need to ship them to DuPont, where they have pediatrics. So they sent the child to us. Of course, we see the child. We have residents and fellows available. We look at this and say, yeah, it's a little displaced, but you know, it's not an emergency. You can be splinted and go home, right? So the kid was in the same splint he'd been in all night, and we just sent him home. But you can imagine this process is a very long, painful process. Every step of the way, he needs to check in, get his insurance evaluated, get his vitals taken, wait, see a provider, have certain expectations managed or mismanaged, and be shipped on down the line. All the while he's in pain, there's fear, there's anxiety. Again, he was told along the way various things, mostly that he needed urgent surgery. And of course, when he got to us, we realized he didn't need that. There's a lot of time that took place. It was about 9 hours of his life going between all of these places. The resources that were utilized at each one of these places were essentially wasted. And money. Every single one of these places, he's getting billed. The facilities are paying people to interact with him and to treat him. And in a perfect world, you can imagine what would have happened if we could have utilized telemedicine or digital health to move my knowledge or an orthopedist's knowledge to where it needed to be at the point of impact. Right when he showed up at that first urgent care, if I was on a tablet or a computer like this, I can see his elbow, I can encourage them to get x-rays. I could have seen those x-rays and said, hey, listen, we understand he's swollen, he's in a lot of pain, just put him in a splint, send him home, and he can follow up with us tomorrow morning and have a nice scheduled visit at 8 a.m. or what have you, and we can talk surgery and talk treatment options. It really would have streamlined and overhauled this whole process and obviated the need to be utilizing all of that time, energy, and resources. We did look at our transfer load over the year 2020 and had about 250 kids. We found about 40% of these kids did not necessarily need to come to the emergency room. Now, they may have needed to come to our system, but they could have easily followed up as an outpatient. So, and again, we found that it took on average about 9 hours, 4 hours at the first institution, 4 hours at our institution, and about 1 hour in transfer. And all these kids were transferred by an ambulance, which you can imagine costs thousands of dollars. And since then, we've now put together a multidisciplinary group of the trauma surgeons, the ER folks, the value-based care organization that we have to really overhaul this process by utilizing telemedicine, again, to move information and knowledge as opposed to moving people. Specialist consultations are something that we're also doing. So you can imagine patients show up to their PCP's office, they show up with joint pain to their rheumatologist's office, and a lot of times they may be uncertain as to how to navigate those patients. So we beam in to those office visits virtually via some sort of HIPAA secure platform, and we can talk, we can educate the outside doc, we can answer questions for the patients and help triage the patient right then and there. Because you can imagine if you're at a PCP's office, you have knee pain, they're not 100% sure what to do, they're just going to ship you off to the orthopod. And by and large, a lot of those things can be managed by the PCP. They don't necessarily need to see us. We can keep the patient in their medical home, keep them in their familiar surrounding, and just move our knowledge to where it needs to go. Econsultations is basically telemedicine, but it's done in an asynchronous fashion, oftentimes over email or some sort of store and forward messaging. Again, we're doing this with PCPs, outside docs. We're giving our access and our knowledge to them. We try to respond to these emails in a couple of days. But again, it often helps prevent unnecessary trips to our office so that we can focus on seeing things that are surgical and seeing patients that are more complex, second and third opinions, things that need to be in front of a surgeon, whereas we can keep some of the more non-operative things, again, in their medical home, in the doctors that they're used to, and we just provide that knowledge while they're being treated. Second opinions, again, this is a huge space now. It's usually in a lot of other specialties, but we're kind of dipping our toe in the water with orthopedics. Again, patients specifically in sports medicine, they get hurt, they get an x-ray, they get an MRI, they get seen. Somebody says, hey, your ACL's torn, you need surgery. A lot of times they just want another opinion. They don't necessarily want to be evaluated. They just want some other surgeon to take a look at things and make them feel better about the choice that they're making, or even provide another option. We do this over the phone, we do this over video, but again, it provides convenient access to a specialist's knowledge and information and advice in a way that's convenient to all parties involved. I can do these things after hours. I don't have to clutter up my clinic necessarily just to see somebody, give them an opinion, and have them go have surgery somewhere else. So that's the benefit of that for us. But also for the patient, they can get peace of mind in a way that doesn't require another day off work, another day missing school, and another clinic visit. So social media is something that's very fun. Again, we're talking about the vein of transferring and moving information. My modality of choice is YouTube and videos. I make videos for my patients, what to expect in the day of surgery. So I do the informed consent process, over video so they can get it the night before in a way that they can watch it at home in a calm environment when they're not NPO and hangry in a loud preoperative holding area. They can watch it, they can rewind it, they can share it with family members. So when they do show up to surgery, they've been primed, they've been prepped by me because it's my video, and I can corroborate and answer any last minute questions that they have. But a lot of times in the pre-op holding area, as you all know, it's very loud, it's chaotic. That may not be the best way to share and transfer information. So I like doing this just to give my patients a little bit of a pep talk, give them a little bit of a leg up prior to them coming to see us. I make videos about how to operate their brace and other durable medical equipment they go home with. I make videos about just basic knowledge about youth sports prevention and injury prevention, all of those kind of bread and butter things that we see a lot of. I try to prep them before the visit. It makes the visit quicker. It makes them more informed. It gets them in and out. So all I need to do is really examine them and come up with a treatment plan. We do counseling for people who are shadowing, people who are medical students and interested in becoming physicians. We do other things, just critiquing kind of what's going on in the healthcare space. My most recent video was a physical exam video on how to evaluate a kid with heel pain or looking for Sever's disease or a growth plate issue. I sent this out to our PCP, so now they feel a little bit more empowered, a little bit more engaged with what they can do, and they can let their patient know that, hey, listen, I can manage this problem. I've been educated a little bit by one of the orthopedic surgeons in our division, and it just provides a lot more information of where it needs to go. This is our first big textbook that we published on telemedicine in orthopedic surgery. So a lot of people feel like you can't even do telemedicine in orthopedics because it's so hands-on. We put a whole textbook together about it. I don't get any royalties from the purchase of this, so this is not a plug for me. It's available on Barnes and Nobles and Amazon. Again, it's purely for academic purposes. I don't get any of the royalties. It all goes to Springer Publishing, but it's something that's out there that can provide a lot of information if you're interested. So just some of the take-home points. I always tell everybody telemedicine is a tool, just like anything else in medicine. It has to be used at the right place, at the right time, for the appropriate patient, by the right provider who's comfortable doing it. It's not necessarily something that's meant to replace clinical care by any means. It's meant to augment and enhance traditional clinical care. But we are pushing the envelope a little bit in trying to make the care that we deliver a little bit more enhanced. But we are not by any means saying that we're trying to replace the traditional in-person care that we all have grown to love. Direct to the consumer, or DTC, is what is out there, and that's what a lot of people know. But there are a whole host of other ways that we can utilize digital health and technology to move information and knowledge to where it needs to go. If you are going to do this, you do have to be flexible. You do have to be patient. As a pioneer trying out doing different things, you can learn from other specialties and other providers. This is very, very popular in primary care, urgent care, ER, neurology, family practice. A lot of other specialties do engage in telemedicine and telehealth. We have a lot that we can learn from our colleagues. And you have to understand that when you're doing something as a pioneer and an innovator, it can be very lonely. Like I said, I've been doing this for 5 years now. Before it was cool. And in the old days, when I had hiccups and things that I was trying to navigate, it's hard because nobody else is really doing it. But you got to fight the good fight and continue to push through. And if it's something that you believe in, that you want to try, I would say just stick with it and try not to get discouraged. And last but not least, have fun and stay well. Obviously, the talk we just heard about wellness and well-being, medicine is a grind, as we all know. Telemedicine is a new frontier, which sometimes can cause stress for us, but that's not the goal. The goal is just to give us something else in our toolbox to be able to provide care to our patients in a way that's convenient to us, convenient to them, but also giving them the care that they need. And that's it for me. I'll stop sharing. And hopefully we can talk and answer any questions that people may have.
Excellent. There's probably there may be a few more questions coming up, but I do have one specifically, Dr. Atanda. Great talk. Yeah. Again, alluding back to the whole guys with white beards being a little bit recalcitrant to moving forward with technological advances with regard to how we practice.
Yeah.
My concern, and not concern, but question for you though is, are you aware of, there were some laws as COVID was going through, it protected telemedicine a little bit better. It made it a little bit safer for us. But are you aware of anything with regard to current tort reform or anything along those lines where
Yeah.
there's a little bit more protection with regard to telemedicine?
Yeah, I mean, that's a good question. There were ways that, they were trying to expand access and utilization of telehealth. They were letting people doing it on different platforms. So before COVID, it was recommended that you did it on a HIPAA secure platform, such as some of the big telemedicine companies put out, like America Well and MD Live, Doctor on Demand. But then people started doing it on FaceTime, Zoom, and different things. We're hoping that a lot of those laws will stay somewhat relaxed even post-COVID. The one big thing that was relaxed was having to be licensed in a state where the patient lives, where the patient is at the time of the visit. And a lot of that did get relaxed because of COVID. It did create a lot more access. Some of that will go back to pre-COVID levels, but I feel like it is not necessarily taking over, but people realize that it's here to stay. So I think some of those policies will remain a little bit lax to encourage more physicians and providers to engage in it.
Excellent. Excellent. Dr. Smith?
Well, I was just going to add, I always try and take something away that's tangible. There can be tons of information in a talk, but I have to figure out like what I'm going to work on next. And I think that the things that intrigued me the most, Alfred, was that concept of incorporating them into the PT visits. Because I for my practice, there's just a lot of like indirect communication and a little bit of phone call communication.
Right.
But, if I'm visually there having a three-way conversation while they're there, I have this sense that really is value added to the experience for the patient and for the communication. So I'm going to take that one away. And I think my last comment is a bit of a commentary on your triage field medicine, concept. The transfers is one issue, but there's also, San Diego County, I serve on the county medical system audit committee, and it's just fascinating to me right now in 2021 that the trauma surgeon has no other information other than radio dispatch information from an ambulance coming in.
Right.
They get the same information we get from an ER. Now, there's really good EMTs out there and there's people that do a really good job of it, but it's not enough information, and we don't have the vitals. We don't have like, the size of that wound. So many things that would allow them to set things. So I just think, and that's true of even just a minor triage, like
Right.
on the field. There's plenty of trauma docs that also do some sports coverage, and there's fractures and injuries out there that can be pretty severe. So that ability to communicate our knowledge as to first aid. I mean, I saw a kid sit on a field for like an hour before they loaded him up on the ambulance, and I was just like, I wasn't the responsible MD on the field, but I was like, can we just get that kid in the ambulance and get him to the hospital? Because if it's as bad as everybody's acting like it is, all he needs is an ER.
Right. Totally.
But so that was really, really helpful information. And I hope it spurred a lot of other people to have some thoughts of how to add to their or supplement their practice with a little bit more telemedicine.
Yeah, that's the idea. I know there's a little bit of trepidation and fear of liability, billing, legal concerns. But I think, folks like me who are just kind of pushing through or working through a lot of those hiccups and trying to disseminate knowledge to everybody else to kind of bring them along. But yeah, you're right. I mean, the traditional path of medicine is, you wait till the patient is in front of you before you can really do what you need to do. And obviously that works, but there are ways to enhance that, and separating how we get that knowledge and information in time and space can really, really prepare us to take care of the patient better, but it also prepares the patient. Think about if you can interact with the patient before they come to you, answer any questions, manage their expectations. They shouldn't wait to be in front of you to realize that you're not going to do surgery or you are going to do surgery. it's nice if they could be prepped and kind of coached before a visit. It'll just make it that much smoother and streamlined for everybody involved.
Excellent.
I've got a question. One of the problems I have with this quick video visits is the documentation part of it. Because when you, the PA or the therapist calls you and you quickly say, oh, yeah, go ahead and do this, go ahead and do that. But then you're in the middle of your clinic and you do all this stuff. And how do you go with the documentation that you actually said what you said and how you said it and when you said it and how the therapist took it? And all that stuff, comes back at some point to bite you if you don't do it right. How do you incorporate that in that quick video connection?
Yeah, I mean, so we document, or I document those similar to just documenting a regular telephone encounter with a patient. And I also do it at a time, and you brought up a good point, I do it at a time where it's not going to be disruptive to my clinic flow. We tend to do a lot of those kind of three-way calls with therapists and such later in the day when our clinic is ending or even over. Again, I've kind of muddled through this for years, so I know that putting it in the middle of a clinic probably isn't ideal. But you find what works for you and you do it at a time where you're not going to be so stressed. If you have patients waiting and all this kind of stuff is going on, it may not be the best time to be kind of sorting through the technology and engaging with therapists. But if you know there's certain days that are lighter, certain days you may have a lot of post-ops, there's a lot of quick visits, that's when I tend to isolate those kind of three-way calls too. And I document, or I have my scribe document them just the way we would document anything else.
Thanks.
Okay. All right. To keep us on a timeline here, I'm gonna pose one more question. It's going to be very quick for the faculty members. We had a question from one of the attendees asking about our recommendations for vitamin D. What we recommend to our patients with regard to vitamin D and calcium after a fracture and injury. So I basically normally tell people to take a multivitamin with calcium and D, and I'm just curious to what the other faculty people do.
Well, I tell the patients, there's quite a bit of evidence-based study on this, that the calcium, the best calcium is the calcium you eat through the plants. The calcium that you take in a pill, it tends to not to really absorb, and sometimes it causes more acidity or it changes into pH balance in the system, and it's not very useful. But the calcium that actually is in the spinach or is in the beans or in whatever, that's the best calcium. And so it's green leafy vegetables, that's your answers, or the fruits. The other questions for the vitamin D, I tell the patients that I ask them if they're in the sun or not. If they're not in the sun, and usually most people are not, I recommend about 2,000 a day, but I'd rather actually do a test and do a actually blood test and see what their value is. Sometimes I'll be surprised. They're like really low. They're like 8 or 9. I mean, they're in the rickets level. And in those cases, you need to start 50,000 for once a week for 6 weeks. And then once the level comes to somewhere above 30, then go about 2,000 or 3,000 a day. And amazingly, some people are fast metabolizers. I don't know why, but some people requires a lot to be able to just hold their level. It's not the one for same level for everybody.